There are multiple different types of hormone replacement therapy. Hormone replacement therapy is used to replace the natural hormones that women's bodies stop producing or minimally produce when reaching menopause. And the replacement therapy is utilized to provide relief of symptoms such as hot flashes, night sweats, and vaginal discomfort. Hormone replacement therapy should be considered only after you've attempted to first introduce lifestyle changes like diet changes, changes in sleep patterns or sleep comforts like having a fan at the bedside, and then looking into CAM therapies as well. If moving forward with hormone replacement therapy is something that is decided to go with, there are different types such as estrogen therapy, which contains only the estrogen hormone, estrogen with added progesterone or EPT, which contains both, as it sounds, the estrogen and the progesterone added separately. And then there are combined therapies as well, such as estrogen with testosterone therapy, which is rarely used and not approved by the FDA, or CEE, which is equine estrogen with a basodoxifene or BZD. Hormone therapy can also be taken one of two ways. It can be taken locally, such as a vaginal ring or vaginal insert, and it can also be taken systemically, such as by mouth or the transdermal patch. Local estrogen therapy includes or involves a low-dose vaginal estrogen therapy that is applied directly to the vaginal tissues. It's primarily used to treat the genitourinary symptoms of menopause, such as vaginal atrophy, dyspareunia, frequent UTIs, vaginal bleeding or spotting, urinary tract symptoms. Progesterone is not required with this as it does not reach the uterus. It is contraindicated with women who are actively being treated for breast cancer, and side effects usually are unlikely. This can also be used for a long period of time. Some of the different types of the local estrogen therapy include Imvexxy, which starts with a 4 microgram estradiol tablet. Start with 1 tablet daily for 2 weeks, followed by twice weekly, and the dose can increase up to 10 micrograms. Then there's Estring, which is a 7.5 microgram estradiol ring. It's inserted into the vagina and the ring is replaced every 3 months. There's the Premarin cream, which is a conjugated estrogen. And you can have the formulation of 0.625 milligrams conjugated estrogens per 1 gram of cream. And generally, we'll start off with 0.5 to 2 grams daily for 2 weeks, followed by up to twice weekly. And then there is the 17B estradiol micronized or estrase cream, where you would start with 2 to 4 grams of the cream for 2 weeks, followed by half of the initial dose 3 times weekly. With regards to the systemic estrogen, these medications are used in circulation through the bloodstream and are often used to treat the vasomotor symptoms of menopause, such as hot flashes and night sweats. Contradictions to the use of hormone therapy include suspected breast, ovarian, or endometrial cancer, history of stroke, heart disease, and DVTs, unexplained vaginal bleeding, and women with chronic liver disease and elevated triglyceride levels. Hormone therapy should only be used for 5 years and no more, and should not be used ideally after the age of 65 years old. There are a couple different options when it comes to types of systemic estrogen therapy. You could include things like creams, patches, sprays, pills, gels. The 17 beta estradiol formula, or 17B estradiol, is the most common used estrogen preparation because it is considered as a human natural estrogen. A couple of the options that you have as far as the systemic estrogens have been listed here for you, and they include estrase, or the 17B estradiol micronized, 0.5 milligrams daily, and you would adjust the dose as needed. the 17B estradiol patch or Menostar, which is 0.014 milligrams per day, and you would apply that patch on a weekly basis. Vivel Dot or the 17B estradiol patch, just another version of the patch. Multiple doses are available for this, and that patch is applied twice weekly. There's Evamist, which is the 17B estradiol transdermal spray. It's 1.53 milligrams daily spray, and you would adjust the dose based on the symptoms and their severity. There's Estrogel, which is 17B estradiol gel, and it's 0.75 milligrams per pump, and you would use this daily. Femring is the estradiol acetate, 0.05 milligrams to 0.1 milligrams daily, and this ring would just be replaced every 3 months. And then there's the conjugated equine estrogens, or Premarin, and that's 0.3 milligrams to 1.25 milligrams PO daily. And again, just as with any of the other ones, you would adjust the dose needed. If the symptoms were getting worse, getting better, you would do it based on symptoms and needs. Progesterone therapy should be added in anytime there is a woman needing the hormone replacement therapy that has an intact uterus in order to prevent endometrial hyperplasia. Progesterone therapies can come in the form of a pill, the form of an injection, such as with Depo-Provera, that would be 150 milligrams injected monthly or 400 milligrams injected every 3 months, and in the form of an IUD that would be replaced every 3 years and is inserted straight into the uterus. With the oral option, the women are given a choice on taking this continuously every day or just on a set schedule or set cycle schedule. The oral route is best taken at bedtime due to the drowsiness effect that may come along with it. There are quite a few different options when it comes to the combined therapies, as you can see here on this slide, all of which are going to contain some form of the estrogen along with some form of the progesterone. Some of them are taken continuously and by mouth, and some of them are transdermal patches that are applied either once weekly or twice weekly. I've listed the most common combined therapies here for you to review. When considering hormone therapy, your initial monitoring would include a baseline health assessment, including an assessment of cardiovascular, breast, and gynecological health. You want to obtain some laboratory tests such as your lipid profile, liver function test, fasting glucose, and possibly a thyroid function test. And then you want to look at the bone health. Depending on the patient's age and risk factors, you might consider a bone density test or a DEXA scan to assess for the risk of osteoporosis. Then when we're looking at the follow-up visits, the frequency, initial follow-up should occur 3 to 6 months after starting hormone replacement therapy to evaluate its effectiveness and potential side effects that the woman might be experiencing. Once stable, the follow-up can occur annually or more frequently if the patient has issues that arise and she needs to be seen. Symptom assessment, ask the patient about any changes in her menopause symptoms and whether the hormone replacement is providing relief or not, so you can determine if changes need to be made. And then side effects, you'd always want to inquire about the possible side effects such as breast tenderness, bloating, spotting, or changes in mood. And you'd also want to determine if these side effects are happening, what significance and what impact is it having on her life to determine whether or not a change in the hormone therapy is needed or not. Just a few other notes when it comes to the monitoring. In regards to the lab monitoring, with the lipid profile, the hormone replacement therapy can impact lipid profile, so it is important to monitor cholesterol and the triglyceride levels regularly. With regards to the liver function test, we routinely want to check liver enzymes to ensure that the liver function isn't being impacted and is remaining stable. With blood pressure, we definitely want to be checking the blood pressure or having them check it at home if they're at an increased risk, because it can influence the blood pressure in some patients. So we'd want to just keep an eye on that. With the gynecological monitoring, we want to do the breast exams at each visit and recommend regular mammograms based on their age and risk factors. And with the pelvic exam, we want to do this to monitor for any endometrial changes or changes in the vagina. With bone health, we periodically would want to check the bone density if the patient is at risk for osteoporosis or has been on the hormone replacement therapy for a long time. With regards to patient education and counseling when it comes to hormone replacement therapy, we do want to discuss the benefits and the risks to each of the options that they have available to them. It's important to reinforce the information on the potential benefits and the risks so they can make an informed decision. You want to discuss any new studies or updated evidence in practice that you have come about recently or changes in recommendation, especially if they've been on the replacement therapy for a long time. You definitely want to make sure that you're updating them on the most recent evidence-based practice. With regards to the lifestyle factors, we want to educate on the potential lifestyle modifications that can improve their symptoms and overall health, such as diet and exercise, and like we mentioned earlier, the sleep modifications. Medication compliance, we want to ensure the patient understands the importance of adhering to their hormone replacement therapy and the risks that they might experience with stopping that abruptly. When thinking about adjusting any of the doses or the therapy, we want to modify the dosage of hormone therapy based simply on the symptom relief or non-relief they're having, as well as the side effects they're experiencing. And then when we think about the types of therapies, we want to consider switching to a different type or a different form of hormone replacement if the current therapy isn't effective or it's causing significant side effects, because we don't want to add to this individual's stressors and problems that she might already be experiencing.